Hello, welcome, and thank you for being a part of WorkSafe's Work-Related Gendered Violence in Healthcare webinar. My name is Cameron Ling, and I'll be your host for this session. This morning, we'll explore the following topics. Why are conversations about gendered violence becoming more common in healthcare? What can be done to increase awareness around the risks and hazards? And what are the steps to prevent and control work-related gendered violence? I am joined by two gendered violence experts today. Charlotte Brunner, Senior Psychological Health and Safety Specialist at WorkSafe Victoria. Good morning, Charlotte.
Good morning, Cameron. How are you?
I'm really well, thank you. Thanks so much for joining us this morning. Joining Charlotte is Simone Sheridan, Sexual Safety Nurse Consultant, People, Culture and Safety at Royal Melbourne Hospital. Great to see you, Simone.
Yeah, great to be here, Cam. Thanks for having me.
No, it's wonderful that both of you could come along and share your insights today. We will be taking questions from the audience a little bit later on, so please feel free to start putting your questions in at any stage in the Q&A box there. Given that the discussion today will touch on themes of gendered violence and sexual harassment, if these discussions bring up anything for you, we encourage you to speak to someone you trust or reach out to one of the services listed in the final frame of this session. Charlotte, if I could start with you perhaps, starting with a definition, what exactly is work-related gendered violence?
Yeah, thanks, Cameron. So work-related gender violence is really any behaviour that's directed at a person or affects any person because of their sex, maybe their gender or sexual orientation, or maybe because they don't adhere to socially prescribed gender roles that creates a risk to health and safety. To paint a bit of a picture of what that looks like, it might include violence targeted directly at someone specifically because maybe they're a woman, maybe they're a young worker, under 30 perhaps, maybe they identify as LGBTIQA plus perhaps, or they don't follow socially prescribed gender roles or stereotypes. It could be that maybe they identify with a culturally or racially marginalised background perhaps as well. What we know is that it can be direct but also indirect. So a person may experience gender violence that's not targeted specifically at them, so they might perhaps overhear a conversation, or they might witness violence directed at somebody else as well. Research shows that it does tend to be primarily perpetrated by clients, customers, patients, or stakeholders. So that might look like relatives of patients perhaps, or maybe patients that are cognitively impaired as well. So that fits about 52% of the gender violence that we see in healthcare. But we also know that fellow employees can be involved as well. So particularly when there's a power imbalance, like perhaps maybe senior medical staff versus trainees. So we know that covers about 40% of the gender violence that we see in the workplace. We know that perpetrators are more likely to be men. So the majority of cases, that's what we see. So about 91%. And regarding its prevalence, international research indicates that more than 2 in 5 healthcare workers have experienced sexual harassment at some point in their careers, and it tends to be underreported. So what we know is those numbers don't really report the full scale of the issue that we see as well.
Charlotte, just to confirm this for our audience, what is the difference to work-related sexual harassment?
Yeah, sure. So basically sexual harassment is a common form of gender violence. So in sexual harassment, and so it's directed again at a person at work-related events, or it might happen between people sharing the same workplace as well. It isn't always obvious. So what we know is that can be repeated or continuous. It can be quite insidious in the background. And while you can see some significant one-off incidents where it happens, exposure at a lower intensity, maybe slowly over time, that can accumulate and can cause significant harm as well. And to, I guess, paint a little bit of a picture of what it might look like, it might involve unwanted or unwelcome touching, maybe staring or leering, suggestive comments or jokes, maybe sexually explicit pictures or posted in the workplace. It might be repeated invitations to go out, lots of emails or messages. It might be intrusive questions about a person's private life or their body, unnecessary contact, so maybe deliberately brushing up against a person, or it could be take the form more of insults or taunts, or maybe sexually explicit physical contact. All of those sorts of things that might come through emails or text messages or social media we see used more these days as well. So yeah, what we know is about 35% of it tends to be verbal harassment. So that might be those jokes or comments, maybe intrusive comments. About 33% tends to be non-verbal harassment. So that's more sexual looks, maybe patients exposing themselves, that sort of thing. About 31% might be physical harassment. So that's unwanted physical contact. So maybe hugging when someone doesn't want to be hugged. Or 41% roughly is what we would call psychological. So that's when maybe someone might feel pressured to go out with someone or something like that. And what we know is sexual harassment is really common, and it is a really common cause for physical and mental injury as well.
Simone, if I could bring you in now, what makes the issue particularly complex in healthcare?
I think it's like Charlotte was saying, we're not only dealing with potential staff to staff sexual harassment or gendered violence, but also from the people that we're caring for. And we know that quite a large proportion of the people that come in through our hospitals and through our care institutions might be suffering from something that might make them more disinhibited than usual. That might be a cognitive impairment, a particular medication they're on, or they might be drug and alcohol affected and then accessing our service through needs. And so this can make things really difficult because our healthcare staff are very focused on providing person-centered care and putting those patient needs first. And so when this sexualized behavior happens in the context of that disinhibition or a delirium or a dementia, healthcare staff will often think, well, this is something that they can understand why it's happening. And so they don't want to blame the patient. So they kind of put their own needs on the back burner and actually focus on what the patient needs in terms of care. But unfortunately, although even in those situations, the patient hasn't intended that behavior to harm necessarily, it does have an impact on us. And we need to recognize that impact. Unfortunately, too, we do have some people who access our healthcare services who do just think it's okay to treat healthcare staff in a certain way. And this is because we're dealing with broad societal structures and norms that make some people think that this is going to be okay. And I think, thinking about healthcare professions particularly, there's a history of sexualization of certain healthcare professions. Like, it's coming up to Halloween. I think if we were to Google nurse's costume right now, we're going to come up with some sexual, or rather costumes that are got some rather sexual overtones to it. And I think back to when I was a junior nurse as well, and I remember working in a rehab centre, and there were lots of get well cards up behind a patient's bed. And some of those cards had, very cartoon approaches to healthcare and bed washes and injections that had pretty strong sexual overtones to that as well. So I think that sometimes influences what people think is okay in terms of how to behave towards healthcare workers.
Yeah, it's a great point. Thanks for that, Simone. I believe you've got a video here for us that you'd like to see us featuring lived experience stories. Perhaps we can have a look at that now.
I was making his bed when he started telling me the joke.
His hand moved behind me when I was helping him with the turn.
He started with asking if I was married.
Did I have a boyfriend?
And the questions just got more and more personal.
He looked me up and down and then told me what he'd like to do if he was younger.
After my colleague left the room, the patient kept making suggestive comments about her.
I felt so uncomfortable, but I just didn't know how to shut it down.
He would wink at me when I walked past.
And the next gesture was more explicit.
I was shocked.
He saw my face and said, "Can't you take a joke, love?"
It was another heart rate joke.
And it was clear what it was insinuating.
I overheard him referring to me as his hot young blonde thing.
And he kept calling me babe. It was just really uncomfortable.
It was just really uncomfortable.
It was just really uncomfortable.
I felt awful.
And really embarrassed.
My stomach tensed up and I didn't know what to do.
I brushed it off.
And didn't think about it much during the shift.
But then I found myself tearing up when I told my partner.
I mean, it didn't bother me that much.
But then I thought about the junior staff on my ward.
And I didn't want them to have to deal with this.
I just felt angry.
I felt helpless.
I felt helpless.
I felt helpless.
Disempowered.
I don't want it to
be like this.
Yeah, really powerful stuff there. Thanks, Simone, for sharing that with us. Charlotte, if I could come to you from a WorkSafe perspective, what are some ways the workplace can try to control behaviours like these?
Yeah, sure, Cameron. So what we like to see workplaces do is use a systems approach from all angles. So what we want to see are ideally some controls in place to help manage employee to employee gender violence that might happen, but also perhaps patient to employee or some of the other types that we've talked about here today. And you can do that using lots of different sorts of things. So for example, you might want to incorporate some training for managers to help them, to help upskill them on maybe how to oversee employees who work with these sorts of hazards, or it might be upskilling employees on how to do particular tasks or how to work in particular ways to try and minimize the risk. It might also look like implementing policy or procedures around expected standards of behaviour, having really clear reporting procedures, having really good codes of conduct, those sorts of things as well. So we want to take a multi-pronged approach where we can. And we ideally want to have some direct on the ground level controls, but also some more embedded controls as well. So when we talk about on the ground controls, that might look like having really good patient risk assessments. So you when you're going in, you know what you're working with. But when we talk about those more embedded peripheral controls as well, what we know is that gender violence has quite a big cultural element to it as well. So the way a workplace can manage that is having really good, perhaps, gender violence policies or procedures in place that are embedded to help set, I guess, a better culture in the workplace around these sorts of hazards as well. What we know as well is that other psychosocial hazards can contribute to these sorts of situations too. So we want to try and control some of the other psychosocial hazards. An example might be where we have high job demands. Maybe employees are really, really busy. And that leaves them at higher risk. Maybe they work with patients alone more often. So you want to make sure you've got adequate staffing, really good rostering practices. Those sorts of things can be helpful to reduce that risk. Or it could be by reducing isolation, by making sure you're working two up in higher risk situations as well. The other thing that we really like to see workplaces do is to try and track patterns of exposure through perhaps incident reporting, or maybe through perhaps local management keeping tabs on the kinds of patients that are in a service at that time. And what that can do is help to proactively monitor the wellbeing and offer more support, or help to maintain employees in their role a little bit better. So maybe you might offer them more breaks, or you might offer them secondments and things like that, if you can see that they've had a really bad run, perhaps, for an example. Yeah.
So what are some of the current challenges to doing prevention and risk management well in healthcare?
Yeah, definitely. So I suppose in the forefront of it, and like Simone mentioned before, so the nature of care that's provided is more often than not direct, and it's client-facing kinds of work. So when you're working in these kinds of settings, it can be easier to perhaps blur professional boundaries. A lot of clinicians that work in these kinds of spaces as well really want to help and support the patient as much as possible. So that can make it a bit harder to set firm boundaries as well. And work is often done in private sorts of environments as well. So if you picture maybe a room in a medical centre, you know, it's private. There's not much visibility over rooms like that. So that can create, I guess, isolated conditions, which can be higher risk as well. So there are all challenges inherent to the role, that there's limited things that can be done about them. The other thing that can be really challenging is seeing lack of collaboration between HR and OH&S departments. So what we know is workplace culture often sits with HR, and that's a really important area to have some, I guess, measures in place to help prevent gender violence as well. So when you see these two departments work well together, that's really exciting, because there can be so much better change made. So you want to set tolerances for certain behaviour, or gender stereotypes or power imbalances by putting good incident reporting in place, or you might want to put in good processes and procedures and things like that. The other thing that we tend to see in this space as well is more inexperienced employees or reliance on labour hire. That can be a difficulty as well. That's often because they're used for understaffing and other reasons. And like I said before, they tend to be some of the other peripheral psychosocial hazards that work in this space too. So there can be complexities around ensuring they're adequately trained or experienced, or perhaps supervised as well. And labour hire do tend to fit some of the risk profiles that I spoke about earlier. So for example, they tend to be younger workers as well. The other thing that we tend to see as well as a challenge is just a lack of definition or a poor understanding of what gender violence actually is. I think in a lot of the kinds of roles that might be exposed to this, a lot of people just see it as part of the job, and they might not fully understand the risks, or they might not fully understand the difference between perhaps gender violence and just violence and aggression more broadly as well. So we really want to try and see workplaces try and draw definitions around all of those different factors as well. Yeah.
Simone, if I could jump to you now, in your experience, what can help?
I think Charlotte's given a really good description of some of those really huge challenges that we're up against. And I think where we need to start is really strong education and using our lived experience workforce. That was part of the reason we designed that video and used our lived experience workforce to help us with that, because we do need to help people understand that this gendered violence and sexual harassment that does play out in healthcare in all of these different ways, that it does cause harm, that it is something that's an OH&S issue, and we need to speak up about it, we need to report it, and we need to look for ways to prevent it. So when we're encouraging staff to speak up and report incidents, we actually need to show them how to do this, because a lot of people haven't necessarily reported an incident of unwanted sexual behaviour before. So actually showing people how to do that, how to flag risk, how to communicate risk at handover is really important. On top of that, we need to make sure that when staff do speak up and disclose or do report an incident, that they receive a really supportive response. Unfortunately, because this is a topic it's been an issue that's been normalised in healthcare for a very long time, there can be sometimes those responses that sometimes minimise, potentially blame, or really just negate the importance of the situation. So thanking people for speaking up, even though we might not have the answer for how to fix everything straight away, we want to know what's going on, because if we can see the problem, that's when we can do something about it. So it really becomes everyone's responsibility here. This is not just reliant on the one staff member who receives the incident, who experiences the incident, to fix it in the moment, but to know that they can go to their organisation that's going to have structures in place and a team response, so that they're not left feeling like this is all my issue to deal with.
Simone, like a lot of OHS issues in the workplace, you put a strong emphasis on prevention. Perhaps for our audience, what does this look like in practice?
Yeah, thank you for that. Look, I think we're really working hard at the Royal Melbourne to create a culture where it's very evident to everyone that these kind of behaviours are not welcome here. And that's important right across the staff and clinical spaces. But as you can imagine, and as Charlotte spoke about, when people walk in through our doors accessing healthcare, it can be incredibly hard to even predict when these incidents are going to happen. But once an incident has happened, or once we've had an indication that these behaviours might be playing out, then we need to do something about it. And that's where our responsibility steps in. Once we're aware of that risk, we need to step into thinking about prevention of further incidents. One of the ways that we're achieving some good prevention, I guess, in this space is through providing early verbal cautions to patients. So we might have ignored some pretty, what we would refer to as low level, I hate that term, in terms of sexual harassment, those comments and jokes that kind of just slip by unnoticed and not attended to. We've actually had we've achieved some success in addressing those behaviours early. So for example, we had a nurse recently on night shift who experienced some pretty yucky comments from a patient that made her feel pretty uncomfortable. And when she spoke to the medical team about it in the morning, they immediately went into that patient's room when they were doing their morning round, and they actually said, hey, we need to talk about these behaviours that happened, and they're not okay. And we need to be very clear about the expectations here, and the nurses will be letting us know if there are any further behaviours. That actually had a really great outcome. That patient didn't use any further sexual behaviours or gendered violence against staff. And not only that, when they had a visitor, that patient had a visitor come in, the visitor was making some comments and jokes that were pretty crass. And the patient actually turned around and said, hey, no, not cool, mate. Like, don't talk to the nurses like that. So that was actually a very effective intervention. But we know that sometimes there's going to be people that aren't able to really understand that early verbal caution because of what's going on for them cognitively as well. And that's where we do need to think about that systems approach. How are we changing our care delivery model? Like Charlotte said, are we having 2 staff at the bedside? Are we increasing the visibility so people are minimising those times where those private interactions are happening? And I think we really need to just not ignore the situations that feel really hard. Sometimes when someone has a dementia or delirium or Parkinson's and there's a disinhibition going on, we can feel like it's too hard. There's not much we can do about it, but we do need to keep talking. There are things we can do in terms of involving the person's family and achieving consistency in terms of how we respond. And we have actually been able to achieve some good success in practice. And I think I just want to talk briefly to something else that gave me hope recently in terms of this prevention space. We had a patient with a cognitive impairment who was coming back into the hospital for some surgery that needed to happen. We knew that in the past there'd been sexual behaviours towards staff. So it was actually a multidisciplinary meeting before this person's admission to kind of plan, okay, what's going to work best in terms of the staffing and what days this person's coming in. for their operation, and how might we most effectively get them through that next transition and home again as soon as possible to minimize the risk to staff. So that gave me a lot of hope that there is a lot more we can do in this prevention space when we start having these conversations.
Great. Thank you so much, Simone. Continuing with you, many people working in healthcare are probably familiar with the response strategy of putting a male staff member in there. What do you think of this approach?
Thanks, Cam. I'm so glad you asked that. Look, I'm not going to be too harsh on anybody who's used this before in the past, because to be honest, before we really started having conversations like this we're having today, it's been the only tool in our toolkit. It's been something that we've used as, we've been doing the best that we can. But what we're realizing is that it's very much a Band-Aid approach, and it stops us dealing with the issue as a whole. On top of that, practicality point of view, we don't necessarily have enough male staff to be able to cover all of these various shifts and areas, but also men don't come in one set, shape and size. So doesn't always have the impact that we'd expect it to. We also know that our male staff might experience gendered violence themselves or other forms of harassment, like Charlotte was saying. And like we heard on that video too, some of our male staff have started letting us know that sometimes a patient or a consumer might start actually talking about other colleagues of theirs in a way that's gendered too, and quite offensive to them. So that also is gendered violence in their workplace. And I think, we need to think about gender equality. And if we are actually requesting male staff for certain types of work, then we are actually preferencing this work for our male staff. And so we might actually, if we've got a casual pool of staff and we're saying, okay, well, we need 3 male staff today to be in these particular rooms, then we might actually be allocating more work to our male staff, and under the guise of protecting our female staff, not giving them that work. And we also need to recognise that people don't just come in 2 genders. We've got our trans and gender diverse staff and our non-binary staff. And so where do they sit in terms of this allocation of a male staff member? So for all of these different reasons, we really are advocating that instead of just putting this Band-Aid approach of putting a male staff member in there, that we start thinking about, okay, if I'm going to allocate a staff member, think about experience over gender. Think about who's got experience, who's familiar with this area, who's going to be able to speak up and get support if they need help, and be able to, who knows the policies and procedures of the organisation as well. That's going to work much more effectively than just allocating based on gender.
Yeah, great points you make there, Simone. Thank you for that. I understand you have a short gendered violence case study you'd like to share with us, Charlotte. Is that right?
Yeah, that's right, Cameron. Yeah. So this is a case I worked on in the last 2 years. And in this case, it was at a hospital, and we had a nurse that made comments about a colleague's sexuality, about their partner and private life consistently over the course of about 3 years. So this case study featured the definition of gender violence and sexual harassment, but also for bullying and harassment and just work-related violence in some of the incidents that happened as well. So it bridged quite a few of the hazards, or the psychosocial hazards that we talk about here at WorkSafe. So the behaviour escalated over these three years to physical touching, shoving, leaning, inappropriate notes being left on this person's locker, verbal threats. I think they played around with their swipe cards as well. And it became quite a serious situation where, some of the people involved sustained psychological injuries as well, which was a really terrible outcome. So when we came in and we worked with the workplace, these are some of the controls they put in place to help prevent these sorts of things from happening again, and to minimize the risk in this particular situation as well. Because obviously when things like this happen in a team, it can be quite hard to repair things and for the whole team to move past it, and to put new things in place to prevent it from happening going forward as well. So some of the things that they did directly to manage the situation were the respective team underwent some special training around bullying and harassment and sexual harassment as well. And something they particularly focused on was bystander impact. So in this situation, there'd been a lot of witnesses and the behaviour was quite overt. So what they wanted to do was just try and, I guess, stomp out wherever they could that bystander effect, so people would intervene quickly. Just like Simone said before, I think in these kinds of circumstances, it's so important to jump on it as soon as it happens. You want to be really responsive to what's going on. So that's what the workplace really tried to focus on doing. And the other thing that they worked on in the particular circumstances was to make sure the incidents were appropriately investigated. So I think from memory, they ended up employing an external company to come in and support them with that because the allegations were so extensive and they'd gone for such a long period of time as well. There were some really good witness reports as well that were included in that. So that helped make the investigation really robust. And I think they did some internal training as well around for local management on how to manage these kinds of circumstances going forward as well, with a few cultural change pieces pinned onto it too, with the support of human resources. And just more broadly, some things that Workplace did as well to try and change that culture and to, I guess, across the board, this applied to this team, but also the rest of the workplace as well, they made sure their reporting systems were a bit sharper. So they included some confidential lines of reporting in their processes, and they set up some slightly different reporting systems and functions as well. So when reports came through, they actually went quite high up and they could keep track of how things were happening on an aggregate level too in the workplace. So that was really helpful. The other thing is they looked at upskilling leadership on how to manage these kinds of situations more broadly as well. So they put them through some training so they knew how to manage these sorts of situations promptly but really sensitively as well. The other thing that we looked at, so the workplace implemented some really good diversity policies more broadly too, again, to just help with that culture change piece. And so they had some really good equality processes and policies in place. They had a diversity team in their HR department. They had some really good performance management processes to address inappropriate workplace behaviours more broadly as well. A really good code of conduct, some really good behavioural standards and things like that as well, more broadly to address the situation.
Great. Thanks, Charlotte. Simone, you've been in your role just over 2 years now. What workplace changes have you seen?
Look, it's been a really exciting time and I've seen so many changes and I can't say they're all directly as a result of my role, but we've seen a lot of legislative changes over this time as well. And society in general is getting better at having these conversations, but I'm seeing that in healthcare. We're getting much more comfortable talking about issues of gendered violence and sexual harassment. We've seen a significant increase in reporting, particularly in reporting patient incidents, but also in terms of our people and culture space, we've seen an increase in reporting. And not only that, we've seen an increase in staff satisfaction with how these reports are being handled, which is really important. We want to see that people are feeling like we are providing a response, we're taking it seriously, and it's a validating and empowering response as well. We're seeing earlier intervention, which is fantastic, like the story I told you from the ward where the doctors quickly stepped in and said that's not okay. And we're seeing that play out really well. We've developed a staff sexual safety guideline to support staff when they've experienced unwanted sexual behaviours from a patient. And that includes a flowchart, but not only a flowchart, but some education around trauma-informed responses as well. Not just in the clinical space though, also in the people and culture space, we've been doing what Charlotte said and been streamlining our reporting processes. And we've actually set up some governance committees because what we need to see in this gendered violence space is we have leadership from an executive level. So we now have a prevention and management of sexual assault and sexual harassment committee that looks at this from a broad point of view, which is really important.
If I could continue with you, Simone, what advice would you give to healthcare staff working in other organisations?
Oh, yes, so much advice, but I'd like to kind of focus on 3 key points. The first thing is that reporting is a really powerful tool that you have. When you speak up, when you highlight risk, when you report incidents, organisations then know what's going on in that space and they can actually make sure that there's support provided. My job wouldn't have existed if people hadn't been reporting the types of behaviour that they'd been experiencing. I'd also ask you to challenge those outdated attitudes and beliefs. So when you hear that, oh, let's just put a male staff member in there and that'll fix it, maybe have a conversation around that. And also when you hear that comment, maybe, oh, look, there's not much we can do because, you know, he's got X, Y, or Z, or it's just a generational thing. These types of things are very outdated and we need to think about, no, what can we do going forward to prevent gendered violence and keep our staff safe? And the final bit of advice is look out for each other. We know that these incidents can impact people differently. We know that for many of us, we've had experiences of sexual violence in the past. And so something that doesn't seem that significant may be quite traumatic for someone. So actually responding to people with kindness and care and making sure that they can get the support they need after these incidents.
Yeah, great. Thank you, Simone. I've got lots of questions coming through here, so I'd love to jump to those now if we could. I'll try and direct them as best I can, but please, if I get it a little wrong, feel free to jump in. This one, I think I'm going to go to you, Simone, on this, and you did touch on it a little bit, but a lot of people just wanting some clarification. How can you manage inappropriate behaviours when the perpetrator has a medical condition that affects their cognition, such as dementia?
Look, it's a very difficult situation to try and manage. The first thing is don't ignore it. I think if we just ignore it and we just keep continuing on as we've always done, we're never going to learn what's going to work. I think when there's a clinical condition that's quite chronic, for example, like dementia, it's really important that we involve the whole team, the multidisciplinary team, and we involve the patient's family. And we highlight, look, we're not blaming your parent or your father or your uncle, whoever's perpetrating these behaviors. We know, we understand it's probably a result of their condition, but we still need to make sure that our staff are safe. And we need to also make sure that the patient's relatives and visitors are also safe as well. So let's have a plan for when these behaviors do happen, that we're going to respond in a consistent way. For people who've got impaired cognition, using the words like, oh, that's sexually inappropriate is probably going to cause more confusion. And so being really clear and direct, one of the things that we're encouraging staff to do is use basic hand gestures. If they're in a situation where they're feeling uncomfortable, maybe saying stop, using both hands up and saying that's not okay, or redirecting the person, stop, I'm just going to do X, Y, and Z now, or I'm going to leave the room and come back. I think it's also really important when people have confusion that we don't slip into using those words that might cause more confusion. There you go, love. There you go, darling, sweetie. Those words that sometimes we don't think about, they might actually cause that person to misread the circumstance as well. So there's just a few little tips, but absolutely, I can't say that we've got a perfect solution, but I think the thing is, don't ignore it. Keep talking within your teams and going, what can we do to mitigate harm? We did have a patient recently at the Royal Melbourne who was stroking nurses, quite like just stroking their arms. And it came from a sense of wanting, it was making the nurses feel quite uncomfortable, as you can imagine. But this patient really wanted something to touch. And so we were actually able to go downstairs there was a shop near our coffee shop and get a really soft, fluffy toy and give this to the patient and just take his hand and put it back on the toy. And that actually had a good impact as well. So sometimes there's interesting and unconventional ways of dealing with this, but we all need to be talking together and going, what can we try? What can we do next?
Yeah, great practical advice. Thank you for that, Simone. Charlotte, I might steer this question to you. How can health and safety representatives, or HSRs, effectively identify and address incidents of gendered violence in healthcare settings? And what role can they play in fostering a safe and more inclusive workplace culture?
Yeah, well, that's a good question. So health and safety reps, they can be so powerful in this kind of space. So much of it comes down, so I think a lot of incidents come through as reports of perhaps bullying and harassment, or perhaps as examples of violence and aggression. So I think a lot of it might come down to the individual to have a really good understanding of the definition of what gender violence and sexual harassment is and what it might look like, and maybe tease out existing incidents that might come through or that they might be aware of, to see if that is actually an element in an incident that might have taken place. And yeah, there's all, collating that information to help perhaps build business cases or help draw awareness to it in the organisation can be really powerful as well. And just consultation is key to all of this. And again, reporting. So if something does happen to you in the workplace that makes you feel uncomfortable and it does fit the definition for gender violence, don't be afraid to report it to your health and safety representative as well. Even if you don't feel comfortable, perhaps going over the details with them, just I guess from an aggregate perspective, to let them know that it's happening perhaps in the area that you work. It all helps to build a case to help influence change. Yeah.
Great. Thanks, Charlotte. I might stick with you on this next question here. A number of people wanting the answer to. In a sector such as retail, what action can employers reasonably take when the perpetrators are members of the public that enter and leave these establishments remaining anonymous?
Oh, okay. Yeah. So a different industry. Look, and we do see gender violence happen in all sorts of different industries, and it's not always where you would expect it either. But yeah, sure. So in retail, so I'm just thinking of what I've seen some stores do. So there can be, just thinking aloud, you could put, I've seen some stores, I guess, put warning letter, or like documents on their windows or perhaps on the front desk saying like, these are the behavioural expectations that we have. It could be perhaps if you can identify higher risk times of day, perhaps when you know certain people might be coming in, you might want to make sure there are more employees on, or if, depending on where maybe the store is or how high that risk is, you might want to employ security or things like that. The other things that you might want to do is you can put bans, I think, for people in stores as well. But there's all sorts of different things that you can do in that space. Yeah.
I appreciate that, Charlotte. Thank you so much. Next question here. I might steer this one to you, Simone, perhaps. The Riskman reporting system, hopefully you're aware of that. Yep, nod there.
I am, yes.
Used by hospitals is not appropriate for reporting this type of harassment due to confidentiality. So it's hard to encourage reporting. How would you suggest approaching this issue?
Yeah, look, there are lots of challenges with our current reporting mechanisms. And for many of us in healthcare, Riskman is the tool that's being used in healthcare. I would really recommend that if this is an issue between sexual harassment or gendered violence between colleagues, Riskman's often not the most appropriate tool to use because it does have confidentiality issues and it does go to such a wide distribution list. I would suggest approaching managers or people in culture directly. And I know that at our hospital, we have an OH&S team that can provide a paper Riskman report so that the people can fill it in confidentially as well. In terms of reporting patient incidents, it is difficult too, because I think there's some people that the confidentiality element does actually stop them from making that report. But I guess if we're dealing with this in client care, we're thinking about how can I help keep my colleagues safe. And so I still recommend using Riskman as the reporting tool. But I can definitely acknowledge it is not a perfect reporting situation, but it's what we have at the moment. So I guess we keep using this one and we keep raising the concerns that we have and raising those concerns higher in our organisation so that hopefully we can have some changes made and some confidential reporting avenues available.
Simone, this one, a direct question to you. Simone, if a member of the public is offensive, verbally aggressive or manhandles a Victoria police officer, they are quite often charged with assault. Why then does the health industry have a genuine reluctance to use this legal tool that is available to stamp out this unacceptable behaviour?
I think you've this person's hit the nail on the head that's so true. And we've actually even had a presentation from VicPol within our health service saying, look, we've made significant changes within the police force. Why are we not seeing those changes in healthcare? Look, I think it's challenging because we weren't trained as police. We were trained as healthcare professionals to be able to provide people with the care they need. And we can understand sometimes that there's reasons behind some of the behaviours that happen. And so we're focused on trying to keep that person safe. I think, though, more and more healthcare professionals are understanding that their safety is really important. And I think, we all saw this over COVID. We need to put our masks on before we rush into that resus. So we need to make sure that we have a safe workforce. I think we do need to build better connections between hospitals and formal reporting through police. I think one of the tricky things is, though, that with reporting to police around sexual violence, particularly, the response that people get from police may not always be the response that they want. And what the process that happens afterwards may be really tricky. So I think there's a genuine reluctance to speak up, particularly when it's a sexual violence or gendered violence. But I think, like the person was asking about in terms of physical aggression and violence as well, this is something that our organisation actively supports. We provide people with time and space and also physical support. There'll be a senior staff member who can accompany them to be able to make that report. But we need to make sure that we keep that person at the centre of this. If they want to report it, yes, but not forcing them into that, because obviously that's quite a process too. But I do think we're making steps in that direction, but something we need to keep talking about.
Simone, I'll keep going with you here, if you don't mind. And this one relates a little bit to that care that you're trying to provide, first and foremost. Where we are not able to affect change to behaviour of a client/patient due to medical condition, how can we balance knowingly putting our staff at risk in these situations with having to service the person?
Oh, it's really hard. And, I think sometimes we sit here holding these two scales of going patient care and staff safety, and we think it's one or the other. But I do think we can work towards providing the safest care that we can, but also making sure that our staff are safe. So, for example, we had a situation recently where we weren't able to change the behaviours that were going on, but we did find that there were some interventions that helped. And sometimes, sometimes it's thinking a bit outside the box. It might actually be going, okay, do we need to keep this person in hospital or in care for as long as we thought? Could we potentially look at other models of care? Sometimes we've used the influence of whether it's family members or at times even security personnel, even just being present, might actually change the way that person responds. I honestly, I think it's an ongoing challenge. I think my role wouldn't exist if we'd already established the answer to this question of how do we balance staff safety and patient care. And I think too, if we're thinking about medical conditions and we were talking before about dementia, we do need to recognize too that sexuality is an integral part of being human. And sometimes when people have a medical condition or a disinhibited or a cognitive impairment, sometimes those behaviors can come out in inadvertent ways. So we might be thinking too, okay, how do we provide dignity and privacy for this person to be able to be themselves and to be able to express themselves sexually in a way that's safe for staff? I do think that there are some situations where it does come down to, like what Charlotte said, of going, okay, well, let's not keep the same staff member in the same situation for days on end. Maybe we do need to think about it being a team approach and sharing that out so that and actively following up with staff members, not just going, oh, well, you're going to be looking after that person. Clearly you're going to have a terrible day, but that's just what's going to happen. But checking in and going, hey, do you need a break? Maybe making shorter shifts in that area. It's very individual, but I think having those meetings where we get people together, use your OH&S team, if you've got an occupational violence team or specialist, use them as well as the medical specialists, get them all in a room together, often with the patient's family too, and go, okay, what can we do? What can we try? I think that's the stage we haven't fully explored yet to see if we're able to come up with some other ways of managing this.
Yeah,
Can I just jump in too, Cameron?
Absolutely, Charlotte, go for it.
Thanks. So that's so true. And I think part of a tidy way to wrap that up perhaps is sometimes in risk assessment. So if you do a really comprehensive risk assessment where you can perhaps identify particular triggers or particular things that might cause the behavior, that can be a really good place to start to understand how to put a really nuanced plan in place. And the example you used before where they got the stuffed toy to pat, that's such a good example of identifying perhaps really specifically what's going on with those behaviors and what are some things you might be able to do to address that. And yeah, like you said as well, you just want to reduce that exposure as much as you can. If you are working with someone that is high risk and that's just the nature of that client, reduce that exposure. So, change your rostering, swap people out, maybe offer, if it's maybe an ongoing client, maybe offer secondment opportunities or bring different people on board, or consider your rostering, having multiple people working with that person as well can be really effective to help make sure they get the care and support that they need, but to also protect employees to help minimize that exposure as well.
I am unfortunately conscious of time because we do have to finish up. There's a lot more questions coming through. I apologize to all those people whose questions I couldn't get to. I'm really sorry. If there's anything specific in there, I'll mention shortly, but the WorkSafe advisory line is also a good one to use as well. I apologize. There's lots of great questions coming through, so many questions on a really important topic. Thank you, Charlotte, for your time today. Really appreciate you sharing your insights today.
Thank you, Cameron. Thanks.
And also a big thanks to Simone Sheridan from the Royal Melbourne Hospital. Thanks, Simone.
Thank you for having me.
It's brilliant to have both of you here and sharing your knowledge and lived experiences, unfortunately, about gendered violence in a healthcare environment. It's wonderful. We hope that everybody has found this an interesting and informative session. This webinar will be available on WorkSafe's website in the coming weeks, so look out for that. We do value your opinion on our Health and Safety Month events. So shortly, we will be sending out an online survey. We'd love it if you could provide your feedback so that we can incorporate your suggestions into our program next year. All respondents will go into the draw to win one of 5 $100 gift cards. And shortly, we will show on screen a list of all the contacts or programs that we have covered today in this sessions. If you have any requests for further information, we recommend you to please get in touch, especially those who ask questions that I was unable to have time to get to. Please remember, if there's something you need to discuss, the WorkSafe advisory line is open 7:30 a.m. until 6:30 p.m. Monday to Friday. And also the emergency line is open 24 hours per day, 7 days a week. So please utilize those services. Thank you so much for being a part of today's webinar.